hello, and welcome to Healthline this Tuesday evening. I'm Jennifer Blomquist, and I'm so glad you joined us tonight. If you're one of our new viewers, you're going to walk away tonight learning something on this show, I guarantee it. It's a very informative program. If you're one of our returning viewers, thank you so much for tuning in again, and you know how it goes. You know the drill. We keep that phone number at the bottom of the screen because we are live here in the studio, and we welcome any of your questions. We have a colon and rectal surgeon with us tonight, and we're going to be talking about kind of a sensitive topic, but one that probably afflicts a lot of people. Maybe it even afflicts you or someone you care about, and she can answer any questions you may have, maybe point you in the right direction for treatment or help. So like I said, I will keep that phone number up at the bottom of the screen. Couple of notes about calling in. First of all, we do not just throw you on the air. There is a very nice woman who will answer the phone, and she will talk to you and give you two options. You can ask the question live during the program anytime, so call whenever, and then I can introduce you on the program and you can ask your question live. That's a great way to do it because the doctor might need to get more information from you to give you a better answer. I totally understand if you prefer to do it the other way, which is you can just give the call screener your question and I'll make sure to ask the doctor the question for you. So either way, you'll get your answer. Let's go ahead and meet our guest tonight. She is the first time on our show. We're so glad to have her with us. This is Dr. Garam Hahn, and as I mentioned earlier, she is a colon and rectal surgeon, and we are going to talk about fecal incontinence, which, Dr. Hahn, we were talking before the show, there's probably a lot of people out there who deal with that or maybe know somebody who deals with that.
Yeah, I think it's a very underdiagnosed condition. You know, some studies estimate that there's probably about 19 million adults in the U.S. who are afflicted with this condition.
And you called it in the notes you sent me the silent affliction.
Yeah.
And I thought that's probably a really good way to sum it up.
Yeah. There was a often quoted paper on fecal incontinence that had that title. I thought it did sum up the condition quite well, the social stigma associated with it. Can cause it to be a very isolating condition.
Oh, sure. You know, and Dr. Hahn and I were talking before the show. I have 6 children, and 2 of my boys have Crohn's disease, and they were quite young when they were diagnosed. One was in 4th grade, and one was just in 6th grade. And it has been. Now they're older. One's going into college, believe it or not, sadly, and the other one's in high school. But it's been a struggle because nobody wants to have an accident. And it's not just that it's a visual thing where somebody might see it. It also smells bad, and especially for somebody younger, whether you're a boy or girl, man or woman, it's just not something that you want to have to deal with. And my boys have done things before where on days when they're not feeling their greatest, they don't want to go anywhere because they're afraid that they're going to have an accident. And I can understand the isolation part of it.
Yeah, there's a lot of other ways that it also ends up affecting people's lives that I think that we don't think about. There's a psychiatric component to it, you know, especially for an older patient who has a caregiver that's helping to take care of them. There's the guilt, sometimes some loss of self-respect. It can lead to worsened anxiety and depression. And then, you know, if you think about trying to hold on to a job while having accidents or bad fecal urgency, it can be quite limiting. So it's not just the costs of the pads and the special clothing and the special bedding, but it can actually cost people their source of income, you know, loss of employment. So I think it's a big problem that is very common that we need to talk about more.
Well, how do you determine if somebody's truly fecal incontinent? Do you have a parameter and say, okay, if you've had so many accidents in a certain period of time, or, you know, what are the parameters that you would use to diagnose somebody?
Yeah, so it isn't really a magical number per se of accidents, but the way we define fecal incontinence is patients who have previously had control of their bowels, having fecal urgency or fecal seepage, and either fecal or gas incontinence for greater than a month. Some definitions use 3 months, but
Okay.
the
and
idea—
this would be regularly occurring?
Exactly. So the
Okay.
idea is that it's someone who was functioning just fine before and now is starting to have trouble controlling their gas and stool.
Do most of the patients you talk to, do they have any control, or is it something where they may not even know that they passed stool, or that they may lose any sensation of anything happening?
Yeah, so that's an interesting question because it is a more complicated process than just kind of the barrier aspect of our sphincters failing us.
Okay.
Like you mentioned,
Yeah.
there is a sensory component of it too.
Sure.
I would say we see the full range of types of symptoms. Some patients have more severe fecal incontinence where they're really confined to their house, kind of like your sons had experienced. They have to
Yeah.
limit their activity or travel because the accidents happen so frequently. Other patients may have kind of a little bit of seepage once in a while, and even though it's not a daily occurrence, still very troublesome when it happens.
So if I assume a family doctor would have to point them to a specialist. This would be something you'd have to go see a specialist for, is that right?
Yeah.
Is it outside of the realm of expertise of like a family doctor for the most part?
Yeah, so what would usually happen is if the family doctor at an annual visit or something identifies this as a problem, then they could refer the patient to come see a colon and rectal surgeon.
Okay.
This is typically managed by our specialty. It involves medications that can help as well. So sometimes the gastroenterologist might be the initial people seeing the patient, but ultimately they usually wind up in our office for this condition.
Is there, and maybe I'm not wording this correctly, is there a cure per se, or do you just, for the most part, have to manage it? Does it ever go away, I guess?
So it depends on the patient. Of course, there's not one thing that works for everyone.
Right.
But, and we approach this problem in a stepwise approach.
Yeah.
We typically start by first evaluating the patient, figuring out why they're having the fecal urgency and incontinence episodes. Sometimes it's not the problem, but a symptom of a different problem that's going on.
Okay.
Some abnormality about the way that the anorectal area is that's causing the seepage or accidents to happen. So step one would be kind of meeting the patient, hearing their story, doing a physical exam to figure out if this is a sign of a symptom of something else. We would typically want to make sure that they're up to date on their colonoscopies if they haven't had their screening colonoscopy, and that can sometimes reveal surprises such as God forbid, anal or rectal cancer, or signs of inflammatory bowel disease, which can alter the way that our anorectal area is functioning, and then also change the consistency of our stools, which plays a very big factor in our ability to control when the stool stays in and when it comes out. So the first step is kind of making sure there's not anything else going on. And then after that, the way that we manage it is by keeping track of how often this is happening, whether there's—
Making a little journal or something?
Okay. So keeping a little diary of the symptoms, and also keeping track of what foods you've been taking, what medications you're taking, because there's certain supplements and medications that can increase the chances this happens. And if it's something as simple as cutting chocolate, as much as I love chocolate, out of my diet. If there's a certain trigger that seems to trigger it more, it can definitely help improve people's lives. And then we usually start by having patients add a fiber supplement or eating a high fiber diet. Fiber helps to bulk up our stools, and it's definitely a lot easier to control something that is kind of one soft formed bulk rather than liquid stools.
Right, oh sure.
And then the first type of medication that we sometimes use is the anti-motility agents that help slow down our stools, allow our GI tract to absorb that water, thicken up the stools, again, making the consistency easier for us to control.
And I just want to remind everybody, since the phone lines have been silent, and I hate to see that because you have so much information to offer everybody. So again, we don't give your last name or anything. You don't even have to tell us your first name tonight. How about that, if you don't want to, if you'd rather not to give your first name or to make up a different name, I guess, because I realize it's a sensitive topic. But I hate for you to miss out on getting some information you need, especially, like I said, you know, I have children that have this, and we have to talk about it all the time. It's a part of our life, and it's going to be probably for the rest of our lives. So I just don't want you to feel embarrassed or not call in because this is something Dr. Handiel does every day. So she could help you out. Give us a call. It's 969-2720. Again, it will still be a free call for you if you're outside of Fort Wayne, as long as you put an 866 in front of there. So it looks like we might be getting a couple calls coming in, so I hope so. I'm sorry, Dr. Hahn. I didn't want to interrupt you, but I know that the time goes quickly, and before you know it, it's over. So you were talking about the medication. I mean, and I know just from different physicians we've had on the program over the years, everybody wants to. You start conservative. You know, I think some people are thinking, well, I don't want surgery right away, but it sounds like you take it kind of slowly and work into other things, see what happens.
Yeah, I'm a surgeon. I love to operate, but I only like operating on people who actually need me to operate on them.
Sure.
So we do like to try the non-interventional things first, because if we can find a way to make people's symptoms and their quality of life better without doing other things, then that's always better.
Sure. So you would try that one, the anti-motility medication and the fiber. How long do you usually have a patient try that before maybe progressing to another treatment?
I would usually have them try that for a couple months to see how things go.
Sure.
And then, if that is not improving the symptoms enough, the next thing that we often consider is having the patients go meet with our specialized physical therapists who work on pelvic floor rehabilitation and biofeedback therapy.
I've heard of that before, even for urinary incontinence as well, the pelvic floor exercises. I've heard that they work really, some people have had really tremendous success with that.
Yeah, with fecal incontinence specifically, 64 to about 89% of patients have improvement with just kind of what we've talked about, plus the pelvic floor physical therapy. They work with the patients to make sure that they are doing the things that they need to be doing with the muscles down there, because our pelvic floor and our anal rectal canal is actually composed of lots of different muscles, and in order for us to retain our stool and not leak, we need them to be doing certain motions, and then in order to defecate, we need them to be doing something else. So what they do with our patients is often kind of retraining that brain muscle connection so that they're able to do what they need to be doing with those muscles down there.
I was wondering when you're talking about that, because I know the urinary incontinence tends to impact older people. Is it part of the aging process, though, that the muscles become maybe weaker? Or is that just a normal progression when you age to a certain degree? Or?
Yeah, I hate to think of it as a normal progression, because I feel like sometimes that implies that it's okay.
Yeah.
But age is definitely a big risk factor. As we age, our muscles aren't quite what they used to be.
Sure, I can understand that.
And it's definitely more prevalent in older patients. They estimate, I guess 45 isn't that old, but in women greater than 45, some large survey they did of over 5,000 women showed that about 1 in 5 women over the age of 45 have this problem.
That issue. You mentioned at the beginning of the show you think it's underdiagnosed, and we were talking before the program that we thought maybe I had read some information suggesting that it was more prevalent among women, but you think that maybe it's just that women are seeking the treatment, and maybe there are more men who actually have the issue, but they're maybe not wanting to look into it or have it treated?
Yeah, historically we used to think that being female was a risk factor because we thought it affected women more.
Yeah.
And we definitely do see more women seeking care, but they did do some studies more recently that suggest that actually men also have this issue too, but perhaps are just not seeking the care for it.
Sure. Well, like you mentioned, there's the social stigma, unfortunately. So we did, Dr. Han, have somebody who called in and they wanted me to just ask the question for them. So this was a woman named Jill, and she says that a friend had sudden diarrhea for months, and Crohn's medication did not help. So what are some other options?
I would have a few more questions to kind of clarify.
Sure.
I don't know
yeah,
if it's possible to get answers for that. I'm curious if the friend is diagnosed with Crohn's disease.
Yeah, I wondered the same thing, because that's usually, I just know from my children having it, they had to have a colonoscopy and a bunch of other tests before they concluded that that was it. But
yeah, so it would kind of depend on what's causing the diarrhea, because there's a lot of things that can cause diarrhea. And if it is diarrhea related to Crohn's inflammation, then the key to getting the diarrhea better would typically be calming down the GI tract, the Crohn's flare, with different medications. There are a lot of different types of medications to treat Crohn's flares, so if one medication is not working, then typically they would try a different kind. Also, some of those medications need a couple cycles for them to really see the effect. If it's not related to Crohn's disease, then investigating what's actually causing the diarrhea would be helpful. If there was no identified cause for it and there's no infection going on, then the friend could try something like Imodium to slow down the bowels.
so there's some not necessarily prescription, but over-the-counter things that they could try. I was just curious, because Crohn's is all about inflammation, but do people who have, most of the patients you see with fecal incontinence, do they also tend to have inflammation in the bowel tract, or not necessarily?
Not necessarily. If it's a patient I'm seeing for the diagnosis of fecal incontinence, typically they tend to be more the patients who don't have other things to be causing fecal incontinence, but they have kind of fecal incontinence as its own entity. Kind of the difference between fecal incontinence being its own disease process versus a symptom of something else going on, such as inflammation.
Okay, got it. All right, well, we have a couple more questions that are coming in. So I feel I have my contacts in, but I can't, I'm really aging. I'm not able to read that monitor far away. So, okay, well, first we had Jill, now we have Jack. I don't know if this is supposed to be a silly joke, but Jack and Jill. So Jack wants to know, if you have fecal incontinence, what are symptoms you should look out for, and how could you treat it over the counter? I mean, you had mentioned if there's diarrhea, there are some things you can buy over the counter, but what are the key symptoms, I guess?
So one of the symptoms would be fecal urgency, meaning, you know, when you feel like you need to go to the bathroom, having to rush to find a bathroom.
Yeah.
And then otherwise it would be, you know, gas or stool leaking out of the bottom without your control. And that could be outright accidents where a lot of stool is coming out, or kind of seepage of the stool and finding some staining in your underwear.
Okay.
As far as ways to kind of treat it at home, if the stools are on the looser end especially, I'd recommend trying to eat a high fiber diet and start a fiber supplement to see if that improves the consistency of the stool and gives you better control. You can also do Kegels exercises to try and help strengthen that pelvic floor, improve your sphincter control. And I would keep track of what foods seem to be associated with the accidents. We know that common triggers are things like citrus, spicy foods, caffeine, chocolate, artificial sweeteners. So you could try eliminating those things from your diet and see if that helps the symptoms. And then if the stools are loose despite the fiber and you're still having a lot of issues, then you could try again Imodium to see if slowing down the bowels helps with the control.
Sure.
And if all that fails, we're always happy to see you.
I was going to say, you can always start with your family doctor, and they can
Yeah.
kind of guide you, from there to maybe a specialist. So, and we had one more where a woman wanted me to ask the question for you. So Sue said she's had diverticulitis and polyps, and she had to have surgery. So she wanted to know if there were any treatments that do not involve surgery, and if there is a cure. So can you just describe what a diverticulitis is? I thought it was a lot of inflammation or like sores in the colon, is that right?
Very close.
Okay.
Diverticulitis is when there's inflammation at an outpouching, a little pocket that develops on the colon wall.
Okay.
So having the pocket itself is called diverticulosis, and then when that gets inflamed, we call that diverticulitis.
Sure.
So we kind of talked about the medication management, we talked about the physical therapy aspect, and I would say those would be kind of the things that we would recommend if you are struggling with fecal incontinence and trying to avoid a procedure. If the physical therapy doesn't work and all of the medications have been reviewed and there's nothing to be triggering it, and we've tried the fiber and the anti-motility agents, there are other procedures that can be considered as well.
Yeah. So you brought the model to show one of them. Actually, I don't want to ignore the model. This is going to be very helpful. So
one of the most effective treatments, surgical treatments that we have for fecal incontinence, if the other things have failed to improve people's symptoms, is something called sacral neuromodulation.
Okay.
And
it sounds scary, but you talked a little bit about it before the show, and it's not that bad actually when you get into it.
So sacral neuromodulation is where we stimulate the nerve that goes to our pelvic floor muscles. It is involved in some of the sensation of the rectum, and by stimulating that nerve with a low amplitude signal, it can sometimes improve the function of that nerve.
Okay.
And by improving the function of that nerve, improve the symptoms of fecal incontinence and urinary incontinence. So it's actually something that's done for both conditions. It's really been around since the 1990s and was approved for treatment of fecal incontinence in 2011. But it's very effective. And it's also something that we do a trial of to see if it's going to help you before we actually do the full implantation.
Okay, well that's nice. And you have a little pink sticker there to mark where. So you said, you were telling me before, you run a metal. It's like a little metal string. You said in that area. Is that right?
Yeah. So this is basically the tailbone, and this is the spine, and this is the little opening through which this S3, the third sacral nerve, runs. And what we do is we use an X-ray imaging to guide us, and we put a little lead that sits through this opening alongside this nerve, and it has 4 electrodes on it, and that allows us to have different settings. And then we stimulate that nerve and what it does is it helps with the sensation at that perineal, vaginal, rectal area.
Okay.
And it improves the muscular coordination of the colon and the rectum and the pelvic floor coordination too. Although we do the trial just to kind of see if it's going to work, it actually works quite well. There's different ways of doing the trial. You can either do it for a week or 2 weeks. And about 85 to 92% of patients end up having significant improvement to where they choose to undergo the full implantation of the device.
No, that sounds, I mean, compared to dealing with the symptoms long term, and again, I hope if nothing else, because sadly we only have like 30 seconds left in the show, but I hope if nothing else, people tonight will just be open to the idea of seeking help, or maybe you are a caretaker for even if it's somebody elderly. I mean, it would make their life so much more pleasant to not have to deal with that on a regular basis? Because it's not going to get better on its own, is that right?
Typically doesn't get better on its own, sometimes gets a little worse with time.
Okay.
There's things you can try at home. There's non-surgical things you can try.
Right.
And then our surgical option does have very good results.
Sure.
About 90% of patients do very well with it long term.
Well, we hope if it affects you that you will take advantage of the options that are out there for you. So Dr. Hahn, thank you so much. Appreciate all of your expertise tonight. Our show sadly is over. It always goes way too fast. I'm Jennifer Blomquist. Take care, have a wonderful week, and we'll see you back here next Tuesday for another Healthline. Bye-bye.
PBS Fort Wayne was made possible in part by
Cancer Services of Northeast Indiana, walking side by side with families on their cancer journey, providing emotional support and practical assistance for yourself or another. Cancer-services.org. Momentum, progress, innovation. Parkview Health knows standing still isn't an option. We must learn, grow, excel, and actively work to advance healthcare for our community and beyond. With technologies that improve access to care and teams of specialized providers, we are moving healthcare forward. Right here at Parkview Health.